Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. It's my pleasure to welcome you to the 5th edition of our webinar series of Moving from Hepatitis Discovery to Elimination, a focus on NIH research, both conducted intramurally and extramurally, bringing that together with perspectives from those working in the field to help us understand how to translate those scientific findings into practice that can advance progress toward hepatitis elimination. Today, we'll be focusing on hepatitis D virus, all aspects of that, as you can see here on the slide: virology, epidemiology, clinical features, diagnosis and management, and treatment. And we have an excellent set of presenters and discussants. Next slide, please. Just to let you know that this is a series of webinars, as I've already mentioned, that are brought together by an organizing committee of representatives of a variety of NIH institute and offices, with the addition of CDC as well. And I want to thank my colleagues in NIH for bringing this webinar together. Next slide, please. And all of the materials from this webinar will join the materials from the other webinars, including the recording of this webinar in full, the recording of each presentation. The slide sets, which are often requested, will be available on the Coalition website at globalhep.org, as well as a synthesis report where we'll bring the information shared in the presentations together in a summary, which we hope will be helpful to all of those to as an additional learning tool. Next slide, please. So let's begin our webinar of hepatitis D virus. It's my great pleasure to introduce my colleague, Dr. Jay Hoofnagle, who's Director of the Liver Disease Research Branch in the Division of Digestive Diseases and Nutrition of the National Institute of Diabetes and Digestive and Kidney Diseases at NIH. Jay has been working in hepatitis research for many, many years on a variety of hepatitis viruses, as well as other forms of liver disease. He's published over 400 original articles on liver disease, and he's past president of the American Association for the Study of Liver Disease. So really, I want to thank him for helping bring together this webinar today. Jay?
Well, thank you, John. It's a pleasure to be here and a pleasure to talk about hepatitis D, which I'm going to call Delta hepatitis because it's easier to grasp which one of the viruses I'm talking about, if I could call it Delta. Delta is probably the least common form of viral hepatitis. So when you talk about elimination, it doesn't sound very important, but it is important. It, for instance, is probably the most interesting virus of the 5 viruses that cause hepatitis. It also causes the worst disease, the most severe disease, which is also the most difficult to diagnose. We don't have a good diagnostic test that's standardized to make this diagnosis. And finally, it has resisted therapy to date. There are therapies, they're not very satisfactory, and it's an area of intense research. So those are the types of things we're going to cover today. The story of Delta hepatitis began with this publication in Gut in 1977, 44 years ago. And for us in the field, this paper didn't make any sense whatsoever. They described a new antigen antibody system in hepatitis B that none of us had seen and couldn't make heads or tail of it. So was it a new antigen antibody system of hepatitis B, or was it a subtype of the surface antigen, or a subtype of the core antigen? That was actually the best explanation. Or was it something else? Was it a different virus that infected people? Or was it an artifact? And all those questions really became answered in the next 5 to 10 years by the first author of this paper, Mario Rossetto, who picked up serum from his patients and picked up a liver from his patients, put them in dry ice and brought them across the ocean to the United States and to the laboratory of Bob Purcell at the NIH. And there, over the next couple of years, they sorted out what this disease was. Next slide. And after, this is a photograph that was taken about 5 years after that. In the back there is Mario Rossetto and smiling. And to his left is Dr. Purcell, really a leader in this field and this virus, as with all the virus hepatitis. And with Mario, there are 3 of the young people he brought later on from Italy to work with Purcell, and were kind of the initial Delta 5, I'd say there. Ferruccio Bonino to Purcell's left, and to his right, Antonina Schmidelli, and to the far right, Patricia Farsi, who actually has stayed with us, and she's with us today. She now is in the the institute that Bob worked in IIT. Next slide. So Delta hepatitis, really as shown by this group early, occurs only as an infection, a co-infection with hepatitis B. It's the least common form of viral hepatitis, but the most severe. And currently, as I pointed out, there are no FDA officially approved serological or virological tests, the things that we need very much to deal with this disease. There's no way of prevention, at least in people who are carriers, and there's no satisfactory therapy. Next slide. So today's agenda will deal with those issues. We have an all-star cast. First of all, Dr. Glenn from Stanford to talk about the virus, something that he's contributed a lot to. Discussing the clinical features and epidemiology, Dr. Norah Terrault from USC, and discussing what's going on now with developing new therapies, my colleague, Dr. Theo Heller from the NIH. After these 3 talks, we'll have a roundtable discussion and a chance to answer questions. So if you have questions, put them in the question and answer box and send them in as soon as you think of them. And Dr. Ward will deal with doling these out to the roundtable discussion. We have Dr. Garcia from the FDA. We have Dr. Teshale from the CDC. Dr. Liang from the Intramural Liver Diseases Branch, NIDDK, and Dr. Patricia Farsi from NIIT. Next slide. So let's begin. Our first speaker is Dr. Jeff Glenn, who's professor of medicine in GI and hepatology and microbiology and immunology. He does it all at Stanford University School of Medicine. And he's the director of the Center for Hepatitis and Liver Disease Engineering. Jeff, let me turn it over to you.
Great. Well, thank you very much, Jay, for the kind introduction and the invitation to participate in one of certainly my favorite topics. And just before I begin, for purposes of full disclosure, these are entities that I've either been a consultant to, have received research funding from, or have an equity interest in. And so what I'll do today is just provide a brief overview of HDV virology, the life cycle, noting preclinical potential targets for future therapeutic interference, but focusing then or highlighting those targets of agents that are in clinical development. So Delta is found everywhere. The only countries that don't report Delta are those that don't test for it or their tests don't work. But if you test properly, you can find it everywhere. Although the percentage of HPV infected patients can vary from country to country, and we'll hear a lot more about that from another speaker. Next slide, please. And this is a molecular virologist view of the Delta virus, highlighting the fact that it has a single-stranded circular RNA genome, which encodes one protein, the Delta antigen, which exists in 2 forms, small and large. And these are surrounded by a lipid envelope in which are embedded the viral envelope proteins. Delta does not encode these proteins, it steals them from hepatitis B. That's all it needs from hepatitis B, but that's the molecular basis for why Delta infections are always found in association clinically with hepatitis B. Delta's net effect is to make the B disease worse. As Jay mentioned, it is the worst form of human viral hepatitis, leading to more rapid progression of cirrhosis, liver cancer, and decreased survival. Around 100,000 people are estimated to have it in this country, maybe 15 to 20 worldwide. And I think we'll also hear more about that. And as Jay mentioned, there are no FDA-approved therapies, but hopefully that is something that will be changing in the near future. Next slide, please. So this is an overview of the Delta life cycle, highlighting the fact that there's an initial attachment and entry event. Then after uncoating, there's transport of the nucleocapsid to the nucleus where replication occurs. And newly replicated genomes then exit the nucleus, associate with delta antigen protein, which undergoes a specific modification we'll speak to in a moment. These then acquire surface antigen at the level of the endoplasmic reticulum, where the virus buds into and exits through the host secretory pathway. Drilling down a little bit further on the next slide, the first event involves attachment to the sodium taurocholate co-transporting polypeptide, or NTCP, on the surface of hepatocytes. This is the receptor for bile acids, but it's also used by HBV and HDV for gaining entry into the cell. And then next slide. After this initial entry and an encoding event, the nucleocapsid, as I mentioned, is transported to the nucleus where replication occurs. This is all RNA-dependent RNA replication. There are no DNA intermediates, no archiving. And the mechanism whereby this takes place is diagrammed on this slide, a so-called double rolling circle model for genome replication, where the incoming negative sense polarity circular RNA genome serves as a template for the transcriptional machinery, which then reels round and round that template, leading to the production of linear multimers, which then undergo a processing event by a ribozyme encoded in the RNA. There's then a ligation event to generate circles of opposite polarity. And then the cycle is conceptually completed in the opposite direction, again, with production of multiple linear concatenamers of the negative strand, which then also have a ribozyme activity and regenerating the incoming form of the viral genome. And next slide, please. During this process of replication, there's also a critical RNA editing event that happens, the net effect of which is to transform an A to a G at a strategic location. And it happens, this is within the stop codon of the delta antigen protein. And so a UAG is now converted to a UGG. And so the translation now will proceed to the next downstream stop codon. And this adds on an extra 19 amino acids to the C terminus of the protein. So what? Well, it completely changes the function of the protein. So the small antigen is required for replication. The large antigen is a transdominant inhibitor, and only the large delta antigen can mediate packaging with the HBV surface antigen protein. And the molecular basis for that is exemplified on the next slide, where within that extra 19 amino acids that's added to the C terminus is a so-called CAX box. The last 4 amino acids is cysteine with 3 amino acids. This is a substrate for covalent addition of prenolipids by host enzymes. These lipids are derived from either mevalonate in our body, either farnesyl or geranyl gets added on to CAX boxes. In the case of delta antigen, it uses the farnesyl. And this is essential for mediating the interaction with surface antigen, because if we prevent its attachment to the CAX box cysteine, there are no particles formed. So if we genetically mutate the CAX box, we can demonstrate genetically the critical role of prenylation. In terms of translate that into a therapy, as we'll hear later on, that's attempted to be done pharmacologically by inhibiting the last enzyme that is responsible for prenolipid addition onto the large delta antigen. Now, there are many host delta interactions that have been described, some of which are categorized here. And these are all potential preclinical targets. So these involve different host factors that involved in nuclear import and export, transcription machinery that's hijacked by the virus for replicating its genome, as well as other delta antigen modifications in addition to prenylation, which include phosphorylation by a variety of host kinase, sumolation, methylation, acetylation. And there's also intracellular transport molecules that have been implicated in the viral trafficking through the cell, and over 100 reported interactions between delta antigen and different host factors. And all of these, again, represent potential targets for therapeutic intervention. Of course, with the big caveat, they require further confirmation, both of their drugability, and that doing that, there's an acceptable therapeutic index. So in the next slide, I'll just start to begin to really highlight the targets of therapies that are in advanced clinical development. Next slide. So the first are so-called entry inhibitors, exemplified by Merkelid-XB, which seek to block the attachment of the virus to its receptor. And the next, we have the so-called nucleic acid polymers, exemplified by REP2139, which seek to prevent surface antigen secretion from the cell as a potential mechanism. Then there are prenylation inhibitors, exemplified by lonafarnib, which pharmacologically block this key step of prenylation, which is required for assembly and release of virus particles. And then finally, there is the endogenous interferon lambda, type 3 interferon, which is proving to be very exciting for Delta. And of course, when Jay talks about, he likes to call it Delta, it's particularly a name we hear a lot about in the news with the Delta variant of COVID. And this interferon lambda also has a very compelling activity against that Delta virus, but that's another discussion. So on the next slide, I just would like to leave you with some take-home messages that Delta is found everywhere, although the percent of HBV patients that are co-infected with Delta varies by country. It has a fascinating collection of biology and is an important cause of human viral hepatitis, and indeed responsible for its most severe form. The study of the life cycle has identified many potential host targets for antiviral intervention. Several form the basis for drugs that are in clinical development, including those targeting entry, prenylation, surface antigen secretion, and interferon lambda signaling. And what's exciting is that all of these have complementary mechanisms of action, so they offer the potential for combination therapy. And I believe we'll hear later on by one of the speakers the first example of combining two novel therapies together to treat Delta. So it's actually a very exciting time to be in this field. Thank you.
That was a terrific talk, Jeff. You say there's a lot of targets, but there are not many targets. The virus itself doesn't have an enzyme that you can safely inhibit, like hepatitis C has 3, hepatitis B has 1. Here, you're talking about host enzymes. And so when you start inhibiting host enzymes, you can get into trouble real quickly. And
well, you know, I always say when you know, all of our other non-infectious drugs inhibit host targets too. So the real key isn't whether it's a host or a virus target, but whether you have a safe, you know, a good therapeutic index, where the concentration where you can inhibit the virus is significantly lower than that where you have side effects. And as we're seeing, I think we have a very nice example of that with the prenylation inhibitors. And the other advantage of a host targeting therapy, of course, is that now the genetic locus you target, because it's not under control of the virus, we predict a high barrier to development of resistance. So the virus can mutate all at once, but it's that's not where we're targeting. And so, and indeed,
what polymerase does it use most?
Yeah, that's been a great question. So it's believed to hijack our own polymerases
Yes.
for that effect. And of course, that's very provocative because those polymerases don't just exist for Delta to come along. And so what
I know.
other...
That's what I meant. You can't do it all. That's terrific. Well, let's go to our next speaker. We're very pleased to have with us today Norah Terrault from University of Southern California. She used to be in Northern California, and she'll discuss the clinical features in epidemiology. Norah?
Great. Thank you very much, Jay, and great to be part of this discussion today. It's an exciting topic. And I'll start with the first slide. Now, it's already been mentioned that, this is a global disease, just as hepatitis B is. And if you look at estimates of what is the burden of Delta, you'll get quite widely varying estimates. Generally, historically, it's been said that sort of 3 to 5% of hepatitis B surface antigen positive individuals are infected with Delta. Shown at the top is a systematic review of 282 studies, and it's looking at it by region globally. And you can see that the proportion of surface antigen positive patients that are Delta positive is 3% in Europe, up to 6% in Africa, and estimated globally to be 4.5%, or 11 million individuals, with the confidence interval being 9 to 19 million. Shown at the bottom is another systematic review. You can see it includes much larger number of patients, 600 of studies, 634. Many of these from China and in non-English speaking journals, so that's why they were able to bring in many more studies. Here you can see the estimate is much larger. Here we're looking at 48 million was the estimate from this. And I think it just sort of highlights the challenges in doing prevalence estimates of Delta. Because as you'll learn from the subsequent slides, our ability to do testing, the assays that are used vary, who we test varies, and that's going to influence our prevalence estimates. Next. But it is clear from the available data that there are some if you could go back, please. There are some hotspots, and those would be Taiwan, Pakistan, Mongolia, historically Italy, although less so now, Turkey, the Amazon basin, and Central Africa are areas where there seem to be really high representation of individuals who have Delta co-infection. Next. Now, if we turn to the US in terms of the estimates here, again, it's a little bit dependent on who you study. Next. So if we focus first, next, please, Lindsay, thank you. If you focus first on studies that are really trying to capture more of the general population of individuals infected with chronic hepatitis B, so looking at NHANES, veterans, sort of maybe not general, but representative of a large national sample, the Hepatitis B Research Network, which is a multi-center study representative of US sites, and then a healthcare system. You can see the prevalence estimates on the right sort of vary from less than 1% up to 3.5%, but most of them around 3%. You'll see also that the assays here are varying, sometimes not even stated in the publications as to how they're measuring the anti-HDV. Next. But if you move to focusing on populations where they're studying individuals who are at risk, so looking at injection populations that inject drugs, specialty populations like hepatology practices, you can see that then you'll find higher prevalence of Delta, not surprisingly, because now you're honing in on groups that are more likely to get exposure. And then I'll highlight finally, next please, that there's the most recent NHANES study, which I think for most of us was sort of a huge surprise and a bit of an outlier in terms of the prevalence estimates here in the United States. They were based on a cohort from 2011 to 2016, again, using the diasorin assay, and they found that of the 113 surface antigen positive patients that were tested for Delta, 42% were antibody positive. So that's definitely a number that's much larger than anything else we've seen in the United States. And again, I'm going to come back to this theme that I think part of this is reflecting kind of the challenges we have with the assays. Next, please. So what about anti-HDV detection? I'm just going to show you two comparative studies. We have no FDA-approved anti-HDV assay or HDV RNA assay. And so when we start to look at studies where they're comparing between assays, we see that there is differences in terms of their sensitivity, specificity, overall accuracy. Here's one study in which the ARUP laboratory is used as the reference standard, and then they're comparing two ELISA kits, one from China, and this is a kit that's used in a lot of the Chinese studies, and then also the diasorin assay, which is from Italy. And it's just to highlight that in this particular study, the diasorin assay performs very well. You can see the assay from China had a reduced sensitivity as well as reduced specificity. Next. And then there was a study using a new assay, and Jeff Glenn is very familiar with this. This is work from his laboratory. It's a QMAC assay, which is a quantitative microarray antibody capture assay. And here, first of all, shown in the table is how the QMAC lower limit of detection compares to, say, the diasorin assay, in this case, an ELISA assay. And you can see that it does have higher sensitivity, can detect antibody down to lower level. And in this study where the QMAC was compared to a gold standard of HDV RNA detection or Western blot detection, it performed extremely well, 100% sensitive and 94% specific. And then when they went one step further and compared it to the diasorin assay, which is an assay that is used quite broadly, they found that the diasorin assay had a false negative rate of 7%, a false positive rate of 21%. And all of that is to say that, you know, there's a variability between the assays. So when we're talking about prevalence, we have to understand what are we measuring it with. Next, please. So in terms of estimating HDV burden, I think we have several challenges in coming up with accurate estimates. The first is just the lack of studies, particularly in the sort of general population of chronic hepatitis B patients. Many of the studies are done in special groups, those that are at higher risk. And often, even when you look at studies, say, for example, from the veterans, only a small proportion of the chronic Hep B patients have been tested. So how we select who gets tested is part of the issue. There's variability, as I've highlighted, in the performance characteristics of the anti-HDV test. And then finally, most of the tests on prevalence are focused on antibody detection. And as we'll see later, not all individuals who have Delta antibody have persistent infection. So similar to other diseases such as hepatitis C, where you may have antibody, but you may not have chronic infection, I think understanding the relationship between the HDV RNA detection is also important in characterizing risk for chronic complications of the infection. Next, please. So I'm going to shift now to transmission and what we know about transmission. And in general, in contrast to hepatitis B, where perinatal transmission plays a very important role, for Delta, this is not the case. And we're dealing with intrafamilial transmission, which can occur certainly at younger ages, but primarily this is an infection which we're seeing it in adolescent and adults. And in the developed countries, such as in the US, it's primarily in the context of injection drug use and sexual contacts. Next, please. And in a systematic review in which they looked at risk profiles, it really captures those risks of really parental exposure. So at the top is shown a meta-regression of 376 population samples from 95 countries. And in this case, they're comparing these risk factors to the general population or to the population of individuals who are surface antigen positive. So what emerges as being risk factors? It's persons who inject drugs, commercial sex workers, men who have sex with men, but also exposure to blood through other means like hemodialysis recipients. And then very importantly, these viruses tend to move together. So HIV and HCV are also viruses that are typically transmitted through these risk behaviors. So it's not infrequent that we see patients who might have triple infections with HBV, HCV, and Delta and or HIV. And then shown at the bottom is a US cohort here, the NIDDK, 91 patients who were Delta positive. And I put this table in to emphasize that in the United States, most of our hepatitis B is in the foreign-born. And similarly, not surprisingly, Delta is also common among the foreign-born. And so in terms of independent factors that influence the presence of Delta is country of origin. Next, please. So there is changes, though, in the epidemiology that have occurred over time since its discovery back in 1977. And this is just one very nice study from Italy where they show how the impact of vaccination is influencing Delta. So we know that if we want to prevent Delta, you prevent hepatitis B. And so you can see here from 1987 to 1997, looking at age-specific prevalences in these seroprevalence studies, that there's a lower prevalence of Delta among younger individuals, presumably those that are getting access to Delta, whereas those that are over the age of 50 who didn't have access to that, they're sort of just aging over time. So they have seen a dramatic drop in the prevalence of Delta in countries in which their vaccination programs have been robust. This has also been shown in Spain and in Taiwan, for example. Next. But the other aspect of the changing epidemiology is that immigration continues and is continuing to change sort of what we see in terms of where Delta is. So shown on the left is a study of a large cohort from France of over 1,000 patients with Delta. And it emphasizes that most of the Delta in France is now imported, meaning among foreign-born. You can see half of their patients are from sub-Saharan Africa, and actually the majority are non-Europeans. And similarly, shown on the right is data from the US, and this again is the Hepatitis B Research Network data, where we have tested for Delta antibody. And just to highlight that among those individuals, most of them are not from the US. The highest among those that were found to be Delta are from Africa, Eastern Mediterranean, and European regions. So this is a disease in which immigration and country of origin plays an important role. Next. So in terms of recommendations for HDV screening, there is differences between the national societies. The AASLD thus far has recommended a targeted approach. And by that, I mean they recommend screening based on country of origin and based on risk factors. That's in contrast to EASL and APASL, where they recommend screening of all hepatitis B surface antigen positive patients at least once. And I think that we all are coming to understand that targeted screening fails in instances because people are not aware of the risk profiles that need to be screened, and that even individuals may not be forthcoming about their risks. And so therefore, this concept of screening all hepatitis B surface antigen positive patients once, I think is certainly gaining traction and is one that I think is necessary if we're trying to get more individuals identified. Next. But the challenge is that we still are lacking FDA-approved assays. So here's the diagnostic algorithm for Delta. So screening is with an antibody test and confirmation of infection done with the HDV RNA testing. But as I've highlighted with just a very few studies, is that the anti-HDV assays are not standardized. We do see that there's variability both in specificity as well as sensitivity. And that I think challenges us in terms of thinking about how we're going to roll out screening algorithms. Fortunately, in 2013, the WHO developed a standard for HDV RNA NAT testing. So at least that brought some uniformity to thinking about the development of such assays. But again, there is variability in terms of the detection limits and dynamic range of the HDV RNA assays that are available to clinicians. Genotype is also mentioned here, but I would say that there's very limited role for this in terms of clinical care at the moment, but I think there's some interesting epidemiology that is still to be learned about looking at both HBV and HDV genotypes. Next, please. Now, I emphasized early on that when talking about prevalence of Delta, we have prevalence of exposure or presence of antibody, and then there's the prevalence of chronic infection. So in the systematic review that was done, they also evaluated prevalence of antibody and prevalence of HDV RNA in various regions of the world based on the studies available. And you can see in the column on the far right that the prevalence of HDV viremia does vary. It's not 100%, so not every patient with antibody is going to be viremic. It varies anywhere from prevalence of 41% in some of the African studies up to as high as 73% in those from the Western Pacific. And overall, it's around the 60% range. So these viremia rates reflect both spontaneous, mostly spontaneous clearance, as well as treatment-associated clearance. But since our treatments are relatively limited at the moment, most of this is reflective of spontaneous clearance. Next. So how does that spontaneous clearance kind of look? And in thinking about that, it's important to realize that we have two patterns of infection that are recognized, and they differ very much in terms of their risk for chronicity. So shown on the left is co-infection, where B and Delta are acquired at the same time. Next. And with this particular presentation, it really is indistinguishable from acute hepatitis B. Unless you test for Delta, you may not even know it's there. And like acute hepatitis B, these individuals have a high likelihood of actually attaining spontaneous clearance, assuming that they're healthy adults. And so high rates of clearance. But what is unique about having Delta as an acute infection, co-infection, is that there is a higher recognized rate of acute liver failure. So it can be more severe acute disease. Now, the other pattern is superinfection. And next, please. In this scenario, you have somebody who has chronic hepatitis B and then acquires Delta. Sometimes this manifests as a flare in somebody with chronic hepatitis B. And so generally when we see flares, we should always be thinking Delta, but it can present asymptomatically. There's a lot of variability in terms of its presentation. But what's key about a superinfection is that the rates of spontaneous clearance in this setting are very low. Next slide, please. In terms of this relationship between the two viruses is also very interesting. If you look sort of across a large body of literature, the sort of main features are that 70 to 90% of patients with Delta co-infection are E antigen negative. So they're mostly E antigen negative chronic hepatitis B. And the typical, what we think about for Delta infection is that the HBV DNA level is low. But as shown in this cartoon, there is some variability in that pattern if we look across patients. And here's a very nice sort of summary in 25 patients. Next, please. What it shows is that the kind of classic is that you have patients who have HDV RNA that is high, HBV DNA is low, and typically ALTs that are elevated. And in this scenario, they found 50%. And as I mentioned, often in studies, it's as high as 70% and higher. Next. But there's also a proportion in which the D and the HBV are moving in parallel, meaning that both are up at the same time and both decline at the same time. So sort of similar patterns. And in this study, 30% of the patients had that pattern. And then finally, next, there is a small proportion of patients in which the Delta is low and the HBV is high. Perhaps this represents sort of the spontaneous clearance phase. It's unclear, but to recognize that there is some variability in terms of the patterns of HBV and HDV that we're going to see when we look at viremia. Next. So as I mentioned, we really have these two scenarios, and what sets them apart is with co-infection, chronicity rates are low, 2 to 7% is the estimate, versus with superinfection, in which case the chronicity rates are 90 to 95%. And then what I'm going to emphasize now is that those individuals with chronic infection are recognized to be this enhanced risk for cirrhosis and for hepatocellular carcinoma. And when we look at mortality rates related to liver-related complications, the estimates are that 2 to 20% higher than individuals with HBV infection alone. Next slide, please. What are the factors that have been linked with cirrhosis in individuals who have chronic HDV infection? Well, presence of HDV RNA, so viremia is important. In some studies where the HDV RNA is not available, a marker of viremia can be the anti-HDV IgM, so that has been shown to be associated as a marker in some studies. And then older age, E antigen negative status, HDV and HBV genotype have been proposed as also being important. And I wanted to highlight the genotype. I think it's interesting, sort of an evolving area. I show you two studies. One's a French cohort on the top, and the second is a Taiwanese cohort on the bottom. And what the two studies showed is that the genotype 1 patient did worse, whether compared to the African genotype 1 and genotype 5 patients shown at the top, or compared to genotype 2 in the Taiwanese cohort on the bottom. But in both instances, a genotypic difference in terms of their risk for cirrhosis and or survival. Next, please. Now, I mentioned that HDV viremia is important, and I think this would make sense to all of us, that viremic patients are the group that are at risk, and I just wanted to try to quantify that risk for you. So this is, again, going back to this French cohort of over 1,000 patients, where they were able to follow patients that were viremic over time. And what's shown on the left is the cumulative risk of cirrhosis. Shown on the right is the risk for hepatic decompensation. And you can see it's the viremic group that is got the very high risk of these complications in this longitudinal cohort. And indeed, the hazard ratio shows a 6-fold higher rate of those complications than patients who did not have viremia. Other factors, male sex comes out as being important for risk, as well as in this case, country of origin. Next, please. And then really this is to summarize the available data from a systematic review in terms of its risk for cirrhosis, HCC, and death. and to give sort of numbers to that risk. We know they're higher than HBV patients alone. The number here is that the cirrhosis risk is somewhere around fourfold higher odds of having cirrhosis if you're Delta infected than without, about a twofold higher rate of HCC, but I'm going to have another slide on this shortly, and a higher rate of death. Although to just to go into the HCC risk a little bit more, I'll go to the next slide. How you study this in systematic analysis is important because there's a lot of heterogeneity in the studies. So this is a very nice analysis where they divide patients into the prospective studies versus those that are retrospective. And we recognize that in general, prospective studies have generally higher study quality. And you can see that the heterogeneity in the prospective studies is much lower than when we include retrospective studies. And when you hone in on these high quality studies, you can see that the estimated HCC risk is a fourfold higher for those with Delta than those with HBV infection alone. Next slide. So just to conclude in terms of the epidemiology and clinical features, I've shared with you that the prevalence estimates are limited I think in terms of their interpretation, based on lack of testing, the testing we have, who's been tested, as well as our ability to kind of generalize what one population offers in terms of prevalence to that of the entire country, for example. The epidemiology is also evolving related to HBV vaccination and immigration. Clearly, I'm sure we'll have more discussion about this, but the diagnostic tests really are at the core here of us being able to advance our thinking about Delta and really get to finding the patients that are infected and offering them treatment. We do have a WHO standard for HDV RNA, which I think is very, very important, but the need to have standardized high-performing assays is key. Not every patient with anti-HDV has chronic viremia. That varies from 40 to 70% across the studies. The patterns of HBV and HDV replication seem heterogeneous, although there is the sort of classic pattern with D being high and HBV DNA being low. There is a higher rate of progression, and that's of course why this disease is so important. Higher rates of progression to cirrhosis and HCC in particular, with HDV viremia appearing to be the most important driver. But I think there's an interesting evolving area related to HDV and HBV genotypes. And with that, I'll close. Thank you very much.
Well, that was terrific, Norah. You covered a lot of ground and made it very clear. Very hard with Delta hepatitis.
It is.
I'm very pleased now to move to our third speaker, my colleague Theo Heller from the liver disease branch, intramural branch of NIDDK, who has been a leader in the field of developing therapies for this difficult disease. Theo?
Thank you, Jay. Can I get the first slide, please?
Yes, coming 1 second.
So I would also like to thank the organizers for inviting me, and I think this is an incredibly interesting and exciting topic. I've always thought that D stands for difficult and dominant, but I think that that paradigm is being challenged, and I hope to show you some of that today. Next slide. We have to step back, and we've heard a lot today about what Delta does, and we have to ask ourselves, why is it that we want to treat this disease? And the essence of treatment is that we want to decrease the death, hepatocellular carcinoma, and cirrhosis that Dr. Terrault spoke about. And we shouldn't lose sight of that. As Ioannidis says, when we develop surrogates of surrogates, we will be misled. As a surrogate of this, we use hepatitis B surface antigen seroconversion, because in the absence of hepatitis B, practically speaking, there is no Delta. And as a surrogate of that, we talk about hepatitis D RNA loss. And we heard about hepatitis D RNA being a significant factor in liver disease progression. And just to put this a little bit into context, about 25% of hepatitis B surface antigen positive liver transplant recipients in Europe are HDV positive. Next slide, please. What are the challenges? Well, Dr. Hoofnagle and Dr. Glenn alluded to it already. There are very few targets. The host is responsible for most replication, and targeting the host is not something that is typically easy or safe to do. There's cell-to-cell spread. So even if you target entry inhibitors, the virus could spread between cells without ever going out of a cell as cells divide, for example. Hepatitis B is integrated. So suppressing hepatitis B doesn't necessarily help further because all Delta needs is the surface antigen. This is really virology at its simplest, but most daunting. Essentially, this is RNA with a ribosome. Furthermore, hepatitis B suppression, as Dr. Terrault already said, is common in hepatitis D infection. This means that suppressing it further isn't necessarily beneficial, and we'll cover this in a little bit more detail further. And the real goal is elimination of hepatitis B because then there is no D. Next slide, please. Further challenges. Often these patients have advanced disease. We heard how rapidly they progress to cirrhosis. They can flare on treatment, and something that has been a particular concern of ours in NIDDK and studies that I've done with my partner, really, Dr. Christopher Coe, is we're concerned about flares on withdrawal of treatment. So if you took a cirrhotic and treated them and then withdrew treatment or stopped treatment at the end of the trial, if they then flared because virus was suppressed and then released, that would be a concern. I will address some of this as well. Hepatitis D suppression is also associated with hepatitis B flares. There's no standardization of testing, as Dr. Terrault said, but also there's no standardization of responses. And there is some literature attempting to address this. We also have to ask if it's really relapse or if it's really a matter of insensitive or inadequate assays, and I'll return to this too. And as has been discussed, there's a lack of awareness. And I would also put in a personal plug for something that we see quite frequently, that cases are referred to, with cases that are referred to us, they're often confused for superimposed autoimmune hepatitis on top of hepatitis B. Next slide, please. We have to state, before talking about anything related in any way to therapy, that vaccination for hepatitis B is the ultimate cure, and that this would lead to eradication of hepatitis D. Next slide, please. I think the future therapies and a lot of the therapies we're going to talk about reflect the successes of molecular virology and cell biology. Dr. Glenn has been a pioneer in this field, and understanding the hepatitis D life cycle has revealed tremendous opportunities. And we're going to come back to that as we go through the drugs. Next slide, please. We have to talk about history. The virus may have been discovered in 1977, but by 1987, there were two back-to-back papers. Dr. Hoofnagle is the first author of the first one, looking at interferon therapy for hepatitis D. This is still something that we're using in daily practice. So it's history and present, and perhaps future, as you'll hear. Next slide, please. The good news with interferon, Dr. Fauci is one of the panelists today, did a seminal study where she treated 41 patients for 48 weeks with interferon alpha. And there were 3 arms in the study. No drug, 3 million international units 3 times a week, and 9 million international units 3 times a week. And the salient feature is that 71% of patients in the high dose had a virologic response. That means became PCR negative. And in the 3 million unit in the low dose, 36% became PCR negative, and none in those who weren't treated. The bad news, next slide, please, is that long-term, it seemed that all of them relapsed. But this might also have been related to PCR sensitivity. And the conclusion was a relapse is common after treatment has been stopped. Next slide, please. However, Delta is never that simple. Delta has always got surprises. And longer follow-up of 36 of the previous patients showed a statistically significant benefit in terms of survival for the high dose versus low dose and the high dose versus controls. And more than that, cirrhosis regressed in 4 patients. This is reminiscent of what's seen in hepatitis B. Next slide, please. This regression of cirrhosis had already been pointed out and published in 1999 by Terrault and Hoofnagle, where they had a single patient, and the trend and the time course of the patient is shown in the upper panel on the right, who was treated with interferon for 12 years and resolved cirrhosis. And the 4 panels in the bottom go from cirrhosis in A to an essentially normal liver biopsy in D. Next slide, please. There are many interferon trials for hepatitis B. There are just some listed here. There are a couple of things that are important. It didn't matter if it was regular interferon or pegylated interferon, response rates were suboptimal. And if you look at response rates, they range from 0% to 43%, with most being in the 20s. The bottom study was something that was done at NIDDK, where patients were treated for up to 5 years. Next slide, please. And I just wanted to highlight something here too, because this is a repeat of what Dr. Fauci had shown so many years before, that if you looked at those patients who had a durable virologic response and essentially a functional cure of hepatitis D, there were 7 of them. And 6 of the 7 were alive at an average of 8.8 years of follow-up. And only 1 of 5 of the non-responders was alive at follow-up. Again, showing that even although response rates virologically or biochemically weren't ideal, there seemed to be a benefit with treating with interferon that extended beyond the simple endpoints. Next slide, please. More problems. So if you look at what I've shown you, all of these are essentially small studies or relatively small studies. There's limited experience with different genotypes, and I agree, genotypes will prove to be very interesting. And most of these patients were genotype 1. Most of the studies use different hepatitis D RNA assays. In fact, most of them were homegrown or sort of in the basement kind of assays. And they use different doses, duration, follow-up, and endpoints, making them difficult to compare. Next slide, please. We have to mention that anti-hepatitis B therapies have been tried for hepatitis D. The first study was done by Terrault at NIDDK, where she treated 5 patients with lamivudine for 12 months, and there was no significant benefit. This has subsequently been repeated by Dr. Udaden, and then the 2 HIDDT studies with Dr. Wedemeyer and Dr. Ranke. And here too, there was no benefit to suppressing hepatitis B beyond interferon, the benefit obtained from interferon. Next slide, please. What about the treatment guidelines? You've already heard that there's no currently approved FDA therapy. PEG interferon for 12 months is recommended. And if hepatitis B DNA levels are elevated, concurrent therapy for hepatitis B is suggested. And the bottom line was referral to specialist centers for experimental therapies. Next slide, please. So what are these experimental therapies that patients will be referred to? The first is interferon lambda, pegylated interferon lambda. The second is bulevirtide, which is now EMA approved and is orphan drug status in the US. The third are nucleic acid polymers. The published one is Rep 2139. And third is, and fourth, actually, prenylation inhibitors, lonafarnib, which has orphan drug status in the US. Next slide, please. Major caveats. Much of this data has only been presented in abstract form. Much of the data is dose, duration, and optimal administration discovery. In other words, not intended to cure. And I know cure is a 4-letter word, but these were not intended to cure. This is more fact-finding. And what I'll try and do is focus on highlights for these 4 drugs. And I also want to point out that for most of these studies, we're using surrogates. Remember why we treat. The first slide, we spoke about death, cirrhosis, and HCC. But here we're using factors like ALT, more than a 2-log decline in HDV RNA. And we have to ask what a durable virologic response is. Dr. Rossetto always brings this up, and he always makes the point that it's very difficult to obtain a truly durable response. It is possible. It is possible. There are patients who have had long-term HDV RNA negative, but we have to be careful how we define it and how we measure it. And that's also where standardized assays come into play. Next slide, please. The first is interferon lambda. This is exciting because there are greater restriction of receptors to the liver and less on hematopoietic cells and in the CNS, making the side effects less. There's a similar efficacy in hepatitis B and hepatitis C with less side effects to regular interferon or alpha interferon. Next slide, please. And the study presented by Theo et al. At EASL showed a phase 2 lambda monotherapy study, 36 subjects, 120 versus 180 micrograms weekly, 48 weeks of therapy, and at 24 weeks of follow-up, 36% had undetectable HDV RNA, and 36%, the same 36% had ALT normalization. I will point out that 6 patients had elevated bilirubin, and it resolved in all. This is very promising. Next slide, please. Let's go back to the life cycle. I'd like to point out 3 areas of interest. The first is step 1, that is entry. The second is nucleic acid polymers, and it's not clear where they work. And the third, prenylation inhibition, which Dr. Glenn has already spoken about. With that relates to assembly. Next slide, please. What about entry inhibitors? This is a mimetic molecule that binds the receptor for hepatitis B and thus D, which prevents entry of the virus into cells. Next slide. It was originally known as Mercledex B, and now it's known as bulevirtide. There are multiple studies that have been presented. The first was in 24 patients, a phase 1b/2a study with 2 milligrams once a week, and was compared to in combination with interferon and interferon alone. And when I say interferon, I'm referring to pegylated interferon alpha. The HDV decline over 24 weeks was significant, minus 1.67, 2.6, and 2.2 logs. In a follow-up phase 2b open label study in 120 patients with 3 different doses, the maximum decline was seen at the highest dose, 10 milligrams, at minus 2.7 logs. This, at the same time, there was a phase 2b multi-center open label randomized trial in 60 patients, where 2 and 5 milligrams of Mercledex B was given with pegylated interferon for 48 weeks. And at the end of treatment, 53% of patients in the 2 milligram group had undetectable HDV RNA and 27% in the 5 milligram group. Next slide, please. Dr. Wiedemeyer recently presented the interim analysis of the phase 3 study. The design is for 150 patients to be randomized to no treatment initially, and then 10 milligrams subcutaneously daily, 2 milligrams subcutaneously daily for the duration of therapy, that's 144 weeks, and 10 milligrams subcutaneously daily. Next slide, please. At 24 weeks, the HDV RNA declined steadily over time in the 2 and the 10 milligram groups without what appeared to be a significant difference. And the ALT tended to normalize over time, but appeared to plateau at about 16 to 24 weeks. Next slide, please. And if you look at the center panel, which is undetectable HDV RNA or more than 2 log reduction in HDV RNA, a decrease from baseline, the 2 milligram group, 27 out of 49 patients met that, and 34 out of 50 met that in the 10 milligram group. Next slide, please. What about hepatitis B surface antigen secretion inhibitors? These are nucleic acid polymers. These are oligonucleotides with activities against the diverse array of infectious agents, and the specific mechanisms of action are still unknown. Next slide, please. I think the most important study published thus far was published in the Lancet Gastroenterology and Hepatology in 2017, where Rep 2139 was given to 12 patients. They got 500 milligrams intravenously for 15 weeks, followed by 250 milligrams intravenously once a week, with PEG interferon once a week for 15 weeks, followed by PEG interferon for 33 weeks. The mean HDV RNA decline was 5.34. End of treatment, 75% of patients were HDV RNA negative. 83% had a 2 log decline, greater than a 2 log decline. And end of treatment, 42% were surface antigen negative. At 1 year, 58% remained HDV RNA negative, and at 3.5 years, 4 patients were HDV RNA negative. 1 patient decompensated but recovered. Next slide, please. This is a busy slide. I want to direct your attention to 2 panels. This is a figure from that paper. The upper right-hand panel shows, thank you, shows the development of hepatitis B surface antibody, or anti-HBs. And you can see that there were patients who developed significant antibody levels. The lower right panel shows the HDV RNA. And in the initial part of the slide, you can see the decline occurs while being given the NAP, continues on interferon, and then in some relapses, but some stays negative. Next slide, please. What about viral assembly and packaging inhibitors? These are prenylation inhibitors, and you've heard that the post-translational lipid modification is essential for membrane interactions, which is biologically important for a variety of cellular proteins, but here for the assembly of hepatitis B. Next slide, please. The first study that was done at NIDDK with Chris Coe as the first author. And there was a placebo group compared to lonafonib 100 milligrams twice daily and lonafonib 200 milligrams twice daily. And patients were given this drug for 28 days and then followed. You can see that there's a dose response curve with reversion to pre-treatment levels after therapy was stopped. Next slide, please. However, a lot of patients had side effects, nausea, diarrhea, reflux, and weight loss. And so to improve GI tolerability while maintaining serum drug levels, ritonavir was added because it inhibits CYP3A4, which is how lonafonib is metabolized. Next slide, please. This led to a study called 18DK0123, which was treatment of chronic delta hepatitis with pegylated lambda interferon. And this was a combination of 2 novel therapies, lonafonib and ritonavir. Ritonavir is used in HIV to increase protease inhibitor levels. So there's a fairly vast experience in using this drug in this setting. And in this study, lambda interferon was pegylated lambda at 180 micrograms subcutaneously weekly, was given together with lonafonib 50 twice daily and 100 milligrams of ritonavir twice daily. The primary endpoints were more than a 2-log decline in HDV RNA after 24 weeks of therapy, so end of therapy, as well as safety, the ability to tolerate triple combination therapy at the prescribed dose for 24 weeks. Next slide, please. And here's the end of treatment data. You could see that there were 5 patients who did not have a 2-log decline or greater. There were 6 patients who had a greater than 2-log decline and 11 patients who developed undetectable or below the limit of quantitation levels by 24 weeks. 77% of patients achieved greater than a 2-log decline of HDV RNA after 24 weeks of therapy. 50% were undetectable, and 23% or 5 patients remained below the level of quantitation at 24 weeks of follow-up. This is very promising. Next slide, please. And here, 1 patient had dose reduction because of hyperbilirubinemia and anemia, and 4 patients were discontinued due to hyperbilirubinemia, and 1 of which also had some ascites. Next slide, please. So in summary, interferon is suboptimal, but it's wonderful for those who respond. We want to suppress hepatitis B to prevent flares, but not necessarily to improve outcomes. It doesn't seem to do that. Science reveals opportunities, and groundbreaking basic science done over the last 20, 30 years has led to multiple new drugs with more in the pipeline. The combinations, dose, duration, endpoints are all in progress, works in progress, and are not clear. But what is clear, if you'll allow me to quote Annie, is that the sun will come out tomorrow. There clearly is a lot of promise, and there clearly is a lot of opportunity to manage this disease, perhaps, and perhaps even, if I can say, cure it. Next slide, please. I want to thank Crisco, who really has been my partner in all of this and helped me with and worked with me through all of these studies and really now spearheads the studies. Dr. Hoofnagle, who started the hepatitis D studies at the NIH, the clinical studies, and has been my mentor. My other mentor, Dr. Liang, who's the branch chief, who you're going to hear from in a bit, and a wonderful collaboration with Jeff Glenn and Iger, as well as Harold Darhari. I have to thank the patients, the fellows, and the nurses who make all of this happen, because nothing is possible without the people who actually do the work and don't give the talks. And lastly, I want to end with that image from Dr. Lau's paper, which is really our aim, to go from cirrhosis to normal. Thank you for your attention.
Thank you, Theo.
It was very nice, Theo. And I'm now going to turn it over to John.
Okay, that's right. Okay. Great, Jay. Well, I'll turn it over to someone else. This is great. We have some great questions coming up, but we also have some great panelists. And we already saw Jake's name on that last slide. And so he's very involved in this level of research. He's the chief of the liver disease branch and the deputy director of translational research at NIDDK. So Jake, just wanted to turn it over to you to give you some opportunity to add some perspectives on what's been presented and any additional information you'd like to provide. Thanks.
Sure, thanks, John. And first, I'd like to thank you and Lindsay for organizing this series of webinars. It's been wonderful. And certainly thanks to Jade and Theo, Norah, and Glenn for putting on a wonderful symposium on hepatitis Delta virus. I would have to admit that I don't work directly on Delta virus, so I don't consider myself an expert, but I'll give you my 30,000 foot view of the sort of the virus. As you know, that the Delta virus requires hepatitis B virus to survive, right? So in my mind, I remind me the saying that HDV is like little brother to HBV. And just like little brother, it goes wherever you goes, and instead of causing problem, wreaks havoc and cramps your styles, right? So in a way, that B is sort of in a very existential presence with Delta. So when you're talking about treating the Delta virus, I think you have to consider hepatitis B virus. So in the sense that if you really want to cure this disease, you probably will have to treat both viral infections in order to cure the virus. Although I do agree data from Patricia, who has shown that even with long-term interferon, that you will have improved survivals and symptoms and sign and progression, which is good. But to cure the virus, I think you're gonna have to target both viruses. So I think that's gonna be the challenge facing the Delta field. First of all, you gotta treat B, and then you gotta treat D. So I think that's really sort of the holy grail that we hope to achieve. But I certainly think with advance in treatments of hepatitis B virus, we will get there in the sense that once we can cure hepatitis B virus, and it's possible that we can also cure HDV virus. I think that's really what I want to relate. And I think this is really exciting virus, very complicated virus, and certainly very difficult to treat. And but we are making progress in terms of finding new targets, new drugs. And so I'm certainly very optimistic about that.
Thank you, Jake. We had a few questions. I think we'll take a few moments to answer those that have been posted. Maybe there's one here for Jeff Glenn, if he's still on. What's the possibility that HDV could be using other glycoproteins from other viruses as part of its replication cycle? There's been a couple of in vitro and in vivo studies in the last couple of years. It's been remarked.
Yeah, I think that's a question very interesting, generated by some of these experiments where at some relatively low frequency, there seems to be some ability in the lab to generate some pseudotypes with different viral envelopes than the HBV envelope that is the natural one for Delta that we've been talking about. How clinically relevant that is a different question. And I think we need a lot more data before we worry too much about that. I think Delta has evolved very well to partner with the HBV surface antigen and other hepatinovirus envelope proteins. So it can go very well with the woodchuck version of hepatitis B or the ground squirrel version. So theoretically, it should be able to pseudotype with other envelopes, but the evolution, I think, really had so far favors that partner that it's co-evolved with.
Thank you.
See, the interesting thing is that you can take the human hepatitis B and Delta and infect a woodchuck with hepatitis B, with the woodchuck hepatitis virus. So Delta gets in and the woodchuck hepatitis B then takes it from there. And you can infect backwards because the hepatitis B has to get it in. There's now a bat hepatitis B that they've infected with Delta, and I think that's very dangerous, don't you think?
Yeah, especially in Wuhan.
Scary.
Theo, you made a nice overview of the various therapeutic options. What's the, what's the sort of the breadth and intensity of research in those several therapeutic options that you laid out? I mean, what's your assessment of the possibilities of having therapeutic options expanding in those different areas that you laid out?
I think that's an excellent question. There are two large phase 3 studies going on right now. The first is with Mercledex B or Belvirtide. I mentioned the interim results, but there's also, Eiger has a fantastic 400 patient study using interferon alpha with lonafarnib and ritonavir. And that study is now almost completed enrolling. And those results will be very important. These companies have been working closely with the FDA. And I think that it's just a matter of time before these drugs are approved. It's incredibly exciting to think that there will be approved therapies for hepatitis D. There are also other people the lambda interferon alone is promising in a simple and far simpler way without the combinations. And that it remains to be seen what happens with that as well. So yes, I think there's a huge amount of energy, very exciting energy.
So Theo, just going back to my point, you have to treat B as well. So therefore, interferon, either lambda and alpha, also active HBV drug, right? So in a way, you are treating both viruses.
Yes.
So I think that may account for the success. If you're going to use a combination of B and D.
I think that's very important. In our initial studies of using just alpha interferon, what we found is when we suppressed Delta, hepatitis B would come back up and they would develop higher levels of HBV DNA. And it's only when we had the nucleosides that you could treat the patient at the same time with that interferon alpha really looked like would be helpful at all. So in Theo's studies, I think almost everyone is also given either entecavir or tenofovir. Is that right?
Yes.
But not in combination with interferon lambda, right? Do you still give nucleoside analogs?
We have been, because we're concerned about the possibility of hepatitis B flares. But you're correct. Lambda
Theoretical is probably not necessary, right?
Yeah.
Thanks. I know I had some question about the ASOD guidelines for treatment. So it was outlined by Theo. There's a recommendation if HDV viremia is elevated, but no real threshold is given, as is the case for hepatitis B. So just wondered if, even from your clinical experience, or since you were the author of those recommendations, I mean, how should a clinician really evaluate when HDV treatment should be initiated?
So Dr. Terrault was the first author. Yes.
Yes.
Well, Theo, I know you have a lot of experience here too, so feel free to chime in. But I think the guidance document was acknowledging that the testing was not there and the data was not there to really support a particular threshold. So remember that our HDV RNA assays, until very recently, sort of having consistent ability to get a quantitative assay was not so readily available. So I think, I think as our tests evolve, both the antibody test for screening and then the HDV RNA testing for monitoring patients on therapy or to diagnose viremia, then I think we can start to look at various thresholds. But I think in the guidance, we were looking to identify individuals in which you believe that the Delta is playing a role in the disease. So we were partnering the viral load with an elevated ALT, similar to the way we think about treating hepatitis B as well, where we look at virus plus an ALT to make a decision about who should be treated. So that was the concept behind it. You can see that the recommendations around Delta treatment were acknowledging we don't have any approved therapies. The data on interferon, are in, it is a therapy, but fairly limited, and that there's clearly a need for us to be looking to put these patients into therapeutic trials where they may get options for new treatments. So we're trying to encompass all of that.
Thank you.
So I would agree with that. I just wanted to make one small point that the HDV RNA is commercially available. We should say that. But there is a commercial test. There is a commercial now, more recently, there's a commercial test that's now available.
Yes, that is correct.
So Norah, since we have you there, there's still a lot of controversy about whether there's any genotypic difference in terms of the disease of various different Delta genotypes. Is there any clear evidence that there's indeed data for that? There are certain genotype may behave differently or cause more severe disease or responds less well, let's say, also.
I have to say I didn't include in my talk about the responsiveness, and so maybe Theo could sort of weigh in on that. But certainly there's an emerging literature around genotypic differences. I shared just 2 studies, but there are others. Generally, the theme is that genotype 1 tends to be the more severe version, whatever it's compared to, whether it's compared to 2 in the studies from Asia or compared with genotypes 5, for example, in Europe, but where more cirrhosis, more liver-related complications in patients with genotype 1. And these are modest-sized cohorts, and not all genotypes are represented. And then I think the other thing that's potentially of interest is what the HBV genotype is. So looking at both the HBV genotype and the HDV genotype are going to be relevant in terms of trying to understand how that might influence natural history. But I put it out there because I think we maybe should be thinking a little bit more about genotype, and it may be relevant for some of the treatments. I think that's less clear, but something to think about for the future.
Great.
I would just say with
the other thing is you see two severe forms of Delta. One is what I call fresh. They have very high enzymes, very active biopsy, and they just look like they need to be treated. The other is kind of the burnt out Delta. They have cirrhosis and it grumbles along. That's a much more difficult form of Delta to treat, and those are the ones who are getting cancer. I think maybe Patricia can speak to this too. She's probably seen more Delta than any of us.
Thanks, Jay. Yes, I agree with you that there are 2 kinds of disease. The one that we are seeing as a result of an old infection, especially in Europe, and the fresh one that are mostly due to fluxes of immigrants that are more active, but they are exactly with the same features of the chronic hepatitis that we have observed in the 80s. So the difference is that one is the results of the old disease that maybe have been infected a long time ago, and the other one is a fresh disease brought into the immigrants' fluxes from region where, HDV is endemic, because also there is a lack of HBV vaccination programs. So these are 2 completely different diseases, I agree, but it depends from the time you are seeing the disease, because you can have a fresh disease that in 5 years, 10 years, it goes into cirrhosis. We don't need to forget that the HDV progresses to cirrhosis in 80% of the patients. So it's the most progressive I would like to make a point regarding the talk from Norah. That was a very clear and beautiful talk, Norah, regarding the importance that although the epidemiology of data, because still there are numbers that does not match together if you consider some of the epidemiological studies. So there are some data that, highlighted 12 millions versus 78 millions. So I think that this pointed out to the need to test for Delta HBsAg positive patients also in the United States. Because until we test these patients, we will never get the real estimate of the epidemiology of this virus, and especially the medical impact that HDV also plays in the United States. So I think that we should advocate testing for Delta even in patients that are HBsAg positive, because otherwise, how can you say that this is due to Delta if you don't test? This is really difficult to understand. I mean, there are some peculiar clinical features, but it's not so simple unless you have a lot of experience to differentiate a chronic hepatitis B E antigen negative with chronic hepatitis Delta. So I think that this meeting should also point out to the need to give the more importance to this virus and to the medical consequences that this virus can have in the community. So that was one, and then maybe later I would like to make some point about the therapy, maybe later.
Okay, thank you very much.
Treatment
Thank
of
you.
hepatitis D.
Thank you. We have some other questions about viral replication, et cetera. I would appreciate if Jeff and Theo could look at those and strive to seek to comment on those as Jake Liang is doing, because I want to turn to our two other discussants and delve into a little bit more about the public health implications of hepatitis D in the United States and get to the questions of screening and availability of testing. I wanted to introduce my colleague at CDC, Dr. Eyasu Teshale, the team lead for epidemiology and research in the Division of Viral Hepatitis at CDC. And he's been working on hepatitis for about the last 14 years. And he's going to give us an overview, as I mentioned, on public health perspectives and some other aspects around hepatitis D prevalence and testing outcomes. Eyasu.
Thank you, John. Can I have the next slide, please? Viral hepatitis infections under surveillance by the CDC include hepatitis A, B, and C. Each state and territory mandates the conditions and diseases that should be reported to health departments when identified by laboratories, healthcare providers, and healthcare facilities. Health departments then notify CDC of cases of conditions that are included on the Nationally Notifiable Conditions NNC list. The NNC list is established through a collaboration between Council of State and Territorial Epidemiologists, the CSTE, and CDC, and is based on conditions for which there is mandatory reporting to health departments, laboratory tests approved by the US FDA, and established CDC, CSTE case definitions. Hepatitis D is not a national notifiable condition. Next slide, please. Since 1999, we have tested hepatitis B surface antigen positive samples from the National Health and Nutrition Examination Survey for HDV. The assay used during 1999 to 2006 was different from that used from 2007 to 2018. The prevalence of HDV positivity during 1919 to 2004 ranged from 4% to 18%. There were no positive samples during 2005 to 2010. However, during 2011 to 2018, positivity was higher and ranged from 12% to 58%. There is no clear explanation for this trend, but it could be due to oversampling of certain populations, variability of estimates due to small sample size, and of course, performance of the assay, which was used for most of this time, which is now discontinued by the manufacturer. Next slide, please. We use data from a large cohort of patients with chronic hepatitis B to determine the number of tested or the proportion tested for HDV. Of 6,300 chronic hepatitis B patients, only 6.6% had HDV test, and of these, only 4.8% had a positive result. Next slide, please. This data is from Quest Diagnostics. Among 13,600 hepatitis B surface antigen positive samples tested from 2014 to 2017, only 1.7% were positive. Next slide, please. This slide shows of 90 hepatitis B surface antigen positive samples from patients suspected to have HDV infection that were referred to CDC lab. 2/3 were anti-HDV positive, and just a little more than half were HDV RNA positive. And the predominant genotype was genotype 5. I'm sorry, genotype 1. Next slide, please. In summary, the prevalence of HDV infection in the United States is not well described, well known. Few studies of convenience samples of surface antigen positive cases indicate low prevalence of HDV infection. HDV test is not widely used and could be due to many factors, including lack of approved tests in the United States. Next slide, please. Effective hepatitis B prevention by increasing hepatitis B vaccination coverage, increasing awareness and linkage to care and treatment of hepatitis B is key for HDV prevention. In 2008, CDC recommended HDV testing at initial evaluation of patients with HBV infection. A recent study by CDC showed that universal hepatitis B surface antigen screening of US adults is cost-effective and likely cost-saving compared to current chronic hepatitis B screening recommendations. These screening recommendations may become available in 2022. Next slide, please. I'd like to acknowledge all who provided information for this presentation, and thank you all.
Thank you very much, Eyasu, for that overview. We'll come back and have you join the discussion as questions come up. But I wanted to move on to Dr. Maria Garcia from the FDA in the Division of Microbiology Devices, and where she's the current Assistant Director for General Viral and Hepatitis. She's been reviewing hepatitis serology and molecular diagnostics devices since she joined the FDA in 2011. We've heard a lot about the value of testing and the problems of not having an FDA-approved test, and look forward to Maria giving some perspectives on the way forward toward a FDA-approved test. Maria?
Hi, thank you so much for the introduction and for organizing this meeting. I do want to say that, we haven't really seen an interest in hepatitis delta diagnostics, so it's great, that you're bringing this to people's attention. And also, as other speakers have mentioned, there are no clear or approved tests for hepatitis delta. Next slide, please. So this slide shows a general schematic of how knowledge and risk of an analyte or device interact for FDA to ascertain the proper classification of a device, class 1, class 2, or class 3. Devices analyzed for which there is the highest risk to a patient and for which we have the least knowledge are placed in the class 3 group. It is possible, as our knowledge of a device analyte increases, this may mitigate the risk of the device, allowing it to be placed in one of the other groups. So as you can see here, especially under the class 2 devices, special controls become a key piece of the discussion. To give you an idea of where we have classified the hepatitis tests that we have reviewed so far, hepatitis A diagnostic devices are currently reviewed as class 2 or 510K or de novo, and hepatitis B and hepatitis C devices are currently reviewed as class 3, also known as PMA. Reclassification of hepatitis C from class 3 to class 2 is in the works, but has not been finalized. And hepatitis delta may be class 3 or potentially class 2 if sufficient knowledge exists to develop special controls. So next slide, please. This slide shows the typical pre-market analytical data requirements. These are similar for class 2 and class 3 devices. And you can see listed the different analytical performance studies that we typically expect to see for our diagnostic devices that we review. And note that the studies and specifications may vary depending on the technology or other unique device characteristics. And there is also a clinical study that is included in the validation, which I have not described here. So next slide, please. And just to give you an idea of the differences between class 3 and class 2 devices. So there are differences, and these include the following, such as the provided manufacturing section information is more extensive in class 3, and the pre-approval inspection is also for class 3 devices. There is the BIMO, bioresearch monitoring visit, clinical sponsor sites, which is performed for class 3 devices, and as well as post-approval requirements, including annual reporting, and validation studies should test multiple lots for class 3 devices. Stability protocols for class 3 may also differ from class 2 devices and may include additional information as well. So this is to give you an idea of how we evaluate these devices and where they may fall within the classification. And next slide is just my email in case anybody has any questions. Thank you very much.
Thank you. So I get from your presentation that no company has applied to the FDA for approval of an HDV diagnostic test.
So I can't speak for whether a company has applied or not, but nobody has been cleared or approved.
Got it.
Yep.
And at class 3, if you're in the class 3, obviously it's more complicated to get FDA approval for a manufacturer.
It really depends. It is perceived as there are more study requirements. I know some people do see that approach as more burdensome, and it does tend to be a little bit more expensive. So I know that sometimes can be a deterrent for some companies to come in, but we definitely encourage companies to start the discussion with us.
Okay.
One problem will be if when you try to approve a drug to treat Delta hepatitis, the FDA is going to require some kind of proof that your assays are accurate, right? So it's kind of a circular problem we're about to get into.
Correct.
That's why I think there should be a push made to license tests for for RNA as well as antibody based on kind of need in this situation.
Absolutely, and we do try to encourage the diagnostic and the drug manufacturers to work together because, you know, a lot of the challenges are in sourcing samples for these validation studies. And that is definitely something that helps manufacturers a lot, is when they can team up with these drug studies.
Can I ask you a follow-up question about what the typical timeline is from sort of, you know, for approval of such tests? Just to give us a sense of if a company was very interested and motivated to do this, what is the typical sort of timeline?
Yeah, so typically PMAs have the longest timeline, and assuming that all the information that we get is absolutely perfect, it will likely take about a year.
So is emergency authorization.
Only vaccine.
Right.
So I have a question for Norah and Theo. So would you recommend that community physician treat Delta patient with interferon, although that's not approved for Delta yet, but there is a benefit? I mean, what would be the sort of the recommendation to community physicians?
I'll just chime in first. I think there's very few community physicians that really have a lot of experience with interferon these days. It's not a drug we use. And those of us have been doing, like a lot of hepatitis C treatment, for example, may have experience, but I think very few bring that experience. So taking on Delta and treating with interferon, I think, is probably something they'd end up referring to a center that would do it. And I guess we're trying to get the word out that they should also be looking for centers that are offering access to clinical trials with new therapies as well.
Thank you.
It's important to point out also that something strange about Delta. They tolerate interferon so much better than patients with hepatitis C. I was very struck by that. I got away with treating patients with 5 million units a day, which would never get away with in hepatitis.
For years too, right, Jay?
For years.
Interferon lambda is even better tolerated than the alpha.
That's good to know.
It may be because they're young and otherwise healthy. The trouble with treating these patients with cirrhosis and advanced cirrhosis with Delta, they can get in trouble very quickly.
I did have one follow-up question for Maria, because there's, we have no FDA-approved test for hepatitis D, yet commercial laboratories are testing for D. And so just explain why that can happen of a commercial lab using a test that hasn't gone through the FDA approval process, please.
Sure. So those laboratories have likely developed a laboratory-developed test, which we also refer to as LDTs. And those are typically under enforcement discretion. So likely they were validated, and CMS usually oversees those.
Okay. That's good to know. I think that greatly helps clarify, that. We'll turn it over to Patricia, but the value of testing, just want to take a little bit of a global perspective for a moment, in resource constrained settings where therapeutic options are not available, are there any other benefits of testing for hepatitis D for patients with hepatitis B? Is there any value in, emphasizing reducing other comorbidities like excessive alcohol use? Is there any benefit in people knowing their status, encouraging safer sexual practices, et cetera? Any perspectives on, on that? Or you think if you don't have a therapeutic option, there's less value or no value in knowing your HDV status?
So I believe that if you make an early diagnosis, you have much more probability that the patient can respond better to any therapy. This has been very well demonstrated even with alpha interferon. But if we leave a patient with a chronic liver disease that we believe is HBV, and instead it turned out to be Delta, and then the patient has an advanced liver disease, then, it's very difficult to treat, because more the patient develops cirrhosis and complication, and more the patient becomes untreatable. Also because it's true that Delta use HBsAg, but the replication of Delta is completely independent from HBV. So all the drugs that really target HBV, nucleoside and nucleotide analogs, have shown no benefit in HDV. So we need some drug that has any effect on HBsAg. But regarding the replication, yes, there is the brother, but this brother is doing anything because Delta is completely independent. In fact, the patients, they do not have HBV DNA high, or the disease is due to HDV and not to HBV. Of course, that the ideal would be to clear HDV RNA as well as HBsAg, but this is very difficult, and this has been obtained only with interferon, regardless the side effects. So now we are using a kind of drugs that disrupt the interaction of HDV with the helper virus, targeting the host, because HDV does not have its own polymerase. But one of the things that I like to ask, especially to Jeffrey, in terms of the mechanism, and also Theo, is this one. If you are using lonafarnib that inhibits farnesylation, okay, and then you have an accumulation of ribonucleoprotein within the cell, and you have a lot, because you know, this is pretty clear from liver biopsy. So my question is, you are using a drug that inhibits the formation, the morphogenesis of the viral particle, because the drug, the virus cannot egress from the cell. But still, all the ribonucleoprotein, including the small and the large delta antigen, is within the cell. So how can you exclude that delta does not have any cytotoxic effect? Because even older studies have shown that delta can have a cytopathic effect. So I believe that in the end, we ultimately need to see what is the clinical benefit of this kind of trial. So I think we need the liver biopsies, especially when you add the lonafarnib with interferon, and lonafarnib has a lot of side effects in terms of diarrhea and weight loss. So when you have a patient that are not very young with other comorbidities, and you know they use and the drugs metabolized by CYP3A4, what is the management of a patient with heart disease and treatment that, you know, include also drugs that are metabolized by the CYP3A4? So I think, I mean, these data, I mean, these new drugs, of course, are important and exciting, but I think we are far away from drugs that the management is easy, you know, when you see patients that have a lot of side effects. If you add also interferon, I don't know if you have any data, because most of these clinical trials are only under abstract. So it's very difficult, good and bad. But I don't know if you can tell us anything about using lonafarnib plus interferon in terms of side effects. A patient with chronic hepatitis D that sometimes it got cirrhosis. So that was something of concern that I'd like to know your opinion and some data if you have. Or Theo, I don't know about.
Thank you. Is that directed mostly to Jay?
Jeff, do you want me to go first? Do you want to go first?
Sure, please.
I can, well, so from a molecular basis, the large delta antigen, yes, it's important to secrete a virus particle, and when you prevent prenylation, then you inhibit that process. But its other has a very potent transdominant inhibitory effect on replication. So when that's prevented from exit, it actually is predicted to have an impairment of the RNA replication process. I think the other thing on a clinical level is, yes, delta has very high copy level in a cell, up to 300,000 copies per cell. And so at that level, any kind of interaction can be hypothesized. But I think what's very comforting is seeing people normalize their ALT when treated with the drug, because that tells you are having a net clinical benefit. And then in terms of interferon, and then I'll let Theo speak to the side effects, but I think these drugs have been evolving in their understanding and use. And we've gone from more severe GI side effects with high dose monotherapy lonafarnib, by the addition of ritonavir, a low dose ritonavir, which is used in many other drugs, able to give much lower doses of lonafarnib with better tolerability. And I think Theo's going to be involved with even a next generation of the use of this, where it will be even better tolerated doses. But even at these current doses, patients can tolerate it for up to a year. And then I think when we talk about interferon, it's really important to distinguish between, in terms of side effects, between alpha and lambda. And of course, I'll let Theo speak more to that, but we've seen from over 3,000 patients now that have been treated with lambda versus alpha in the context of C, B, and now D, that there's a significant difference in tolerability. And even in the delta studies, that monotherapy that Theo quoted, many of those patients had been on alpha before, and they related it was like night and day. but I'll let Theo speak a little bit more to.
Yeah.
side
No,
effects
I
he's
agree,
been
but
combined from.
you don't think that there is the need in terms of endpoints also to check the liver pathology, since we don't know?
So we agree with that. Patricia, we agree with that. And we do, our studies include liver biopsies. The study that I showed has a liver biopsy at the beginning and at the end of follow-up, because we think liver pathology is very important. And particularly at a place like the NIDDK or the NIH, where we can do that sort of study, it's particularly important to explore as much as possible and to understand the data as deeply as possible. I completely agree with you and the importance of liver biopsies in this setting, particularly when it's unknown. I will also point out that the 22 patients I presented who had the triple therapy all got through the study fine. Some of them did have cirrhosis. Your question about an older person in their 60s or 70s with heart disease and on multiple cardiac drugs, I have not treated many patients like that. I think regardless of CYP interactions, that's going to be a difficult patient to treat. Practically speaking, most of our patients the patients referred are much younger, not on multiple medicines, and we have not had a problem getting people through the triple therapy with lambda interferon. The side effect profile is very different. I'll also agree with what Jay said earlier. In the long-term interferon study, one of the patients was treated for 14 years. He was my patient. He had no problem. He was completely fine, minimal side effects. It's incredible. It's incredible how patients.
I agree, because I treated with 9 million units and I didn't have any withdrawal from the study. So I agree that they tolerate it very well. But when you add the interferon, maybe lambda has less side effects with lonafenib. I have colleagues that are treating, but there are a lot of limitations in terms of drugs, antibiotics. So you must get the right patient to get this kind of treatment.
I'll also tell you that maybe the simplest way to put it is when we look at patients for our studies, we have very few who don't come into the study. Of the patients referred to as consecutive patients, it's a small percentage. It's less than 10% of patients who don't qualify, and that's unselected. That's just as they refer to us. So I don't know. Maybe we're getting referred patients who there's a selection bias before they come to us, because Dr. Terrault will not send us a patient she doesn't think is going to be able to travel to the NIH, and Dr. Glenn wouldn't send us a patient who he doesn't think could walk up the stairs. So there is obviously a selection bias before they even get to us. But once they get to us, we have not had difficulty.
I think another thing to point out is that Delta hepatitis in America is largely a disease of immigrants. And I believe the majority of your patients, Theo, are from Mongolia or Eastern Europe or Africa. It's very And I think there's a secret to the epidemiology we don't understand. We have countries where it's very, very frequent, and right next door, it's not. I had asked Norah about Afghanistan. We know that Pakistan is a very high-risk area. Do we know anything about Afghanistan, where we're going to have quite a few immigrants from there, I guess?
Right. They definitely need to have a screening. Variety of questions around testing in the chat. One from Dave Thomas about what about testing HDV RNA instead of an antibody? How clear are the ASOD guidelines regarding the type of testing that should be used in the management of hepatitis D? Norah?
Well, we recommend an antibody test as a screening test, and then the additional HDV RNA testing would come in those as a confirmatory test, very similar to our algorithms for other viruses, as we start with a serological test. I think maybe what Dave is getting at is, we have some challenges with the antibody assays, and ultimately what we care about is if the patient is viremic, and that would be the patient we'd be interested in sort of targeting for these various treatments that we're talking about. But, in general, there's a differential in terms of cost. As I sort of indicated before, I think that at the time that the guidance was written, the HDV RNA quantitative tests were not where they are today. Today we have, several labs offering that. So it's evolving, but I think if we had a strong antibody test, and I think, I could invite Jeff to talk about the QMAC test, because I think it's very interesting, because the QMAC test as an antibody test also has high positive predictive value for viremia. So I could see that you could use an antibody test and have a lot of information about A, were they exposed, and B, are they likely to be viremic? And that might be a very nice strategy from the point of view of thinking about a screening test for a population.
Well, the other question is, would the insurance reimburse for the screening test if it's not approved, right? Because we know that it's not approved test in the US, so the insurance company may balk at it. So you're not going to be able to screen a lot of people for that.
I think there's been a lot of chat about the approved, not approved. I mean, there are assays, and I think Theo made that comment too. I don't want people to leave this seminar thinking that there aren't an access to tests. You can get them through the commercial lab, but as yet, none of them have made the FDA approval, have gone through that FDA approval process and are approved as yet. But they exist.
Okay, thank you. Two other questions, clinical questions. One, any information to share regarding co-infection with HIV, HBV, and HDV? I know in our immigrant populations that might be rare, but I didn't know if there was any data that comes to mind that can be shared at this time.
The phase 3 study for bulevirtide in Europe is not excluding HIV for patients who are well controlled, and I would say 10, 15 years ago, we were referred more patients who were HIV co-infected. It's become far less frequent recently. This is a problem. It's also a problem because a lot of patients are treated with drugs that would suppress hepatitis B, like tenofovir. And what we have seen is unrelated to hepatitis D in that setting. Sometimes when they have the antiretrovirals stopped or changed or halted for some reason, we've seen hepatitis B flares, which have been significant. But I think that's a really important population to be aware of and sensitive to and to test them.
Thank you. The other question was around liver transplantations. Maybe this is another question for Norah. Is any differences in outcomes of liver transplant for hepatitis B versus hepatitis B and HDV co-infection?
Well, the data that exists suggests they do very well with transplantation. Probably because, in fact, they typically go into transplant with low HBV DNA levels, and now we use prophylactic therapy that typically prevents the emergence of surface antigen. And so as a consequence, because our HBV prophylaxis therapies are so good, we can actually concurrently prevent Delta. So those patients do extremely well post-transplant. We don't do anything specific to prophylaxing the Delta. We just prophylax the B.
Okay, thank you. I don't want to get my colleague Eyasu off the hook here without a question. So there was a question regarding how can testing for Delta be recommended when there's not an FDA test? Eyasu, have any thoughts on that, or is this an opportunity for our CDC and FDA to get together and see how we can promote some applications for testing?
I think, yeah, it's probably something that we should work jointly on this. From CDC's perspective, we really like to see a good test because we need to have a good estimate of the problem. We need to do better surveillance work in the field of Delta infection, but having the right test, particular test approved, still lies in FDA. Within the division of viral hepatitis, we do a lot of research on the testing for Delta. We're currently working on a new antibody, in-house antibody test, and we're also working on an in-house RNA test. This would be very useful as we embark on the new cycle of the enhanced samples. So that would probably give us a better estimate and also help us resolve some of the issues that we had in the past in terms of the very high estimates that we had.
Thank you. That's great. The presentation's been great. I don't know if anybody else has any closing remarks. I'm about to turn it over to Jay, but this has been a fantastic webinar. It's a great overview on a variety of different aspects for hepatitis D. Please fill out this evaluation so we can see how well we're doing in with these NIH research webinars. And then also just want to alert you that the next webinar will be on October 14th, where we'll be looking into perinatal hepatitis B and hepatitis C and new opportunities for prevention, screening, and treatment. And if you're registered for this webinar, you will receive a notice in the future about that one coming up on October 14th. Again, in collaboration with NIH colleagues. So thank you all again. And Jay, I'll turn it over to you for final remarks and a farewell.
John, thank you for hosting this on one of my favorite topics, Delta hepatitis, which, as you see, is such an intriguing virus and a real challenge. And I think it needs to be met. So what I would advise everybody to do is, yes, test people who have hepatitis B antigen for anti-Delta. And if you find it positive, refer it to one of these trials of therapy. It will get there eventually.
Yeah, thank you.
Right.
Thank you.
Thank you.
And goodbye.
Okay.
Bye, everyone.
Good seeing everyone.
Bye.
Bye-bye. Bye. Great job, everyone. Great. That was fantastic. Thank you.
Thank you to all of you.
Yes.
Great. Bye.
Thank you, Jeff.
Take care, bye.
Eyasu.